Greetings. This is my lecture titled Pain from Synapse to Consciousness. I will spend the next hour or so discussing pain from its fundamentals to where we stand currently. I will spend probably half of the time of this lecture specifically discussing our general concepts of what is pain and what is the machinery underlying pain, uh, and how, in many ways, we conceptualize that currently. Then I will spend the rest of the time discussing chronic pain, which is something that I have dedicated a large part of my life studying. We have lots of evidence about its underlying mechanisms and what are the questions and how some of these questions, in fact, directly relate to the clinical status of chronic pain and clinical application of treatment options, uh, potentially. So let me get started. So fundamentally, uh, this is the definition that the International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. The definition is very general. It is agnostic to mechanisms, and it is simply describing how one experiences pain and how one generally describes pain from the subjectivity of pain. Uh, uh, and as a basic scientist, I'm interested in the components that create this perception. What are the underlying uh, uh, fundamental mechanisms behind it, and also how pain has evolved over time across evolutionary scale. I want to discuss some of those concepts as well. So let me begin with, before talking about pain, perception in general. I mean, this little slide here, should all agree that we can see not yellow, green and red apples, and they look quite fresh and tasty, perhaps. On the other hand, what information creates this perception? Right? If I actually put a spectrometer on top of this picture, I will not see the red and the green, right? I will see essentially a flat spectrum of light waves of different wavelengths. However, the machinery in my eye and in my brain filters all that information away and extracts specific wavelengths with which we can identify this as red and green. In fact, the visual system of a bee or a fish will see these apples in very different colors. We know that because we know their photoreceptors have a very different light spectrum. But importantly, there is an objective structure here that I visually extract specific information from that to make a conclusion about things that, as an organism, I'm interested in. Apples are good for humans, so I would like to know that information. Let me continue that I sort of gave you a very brief overview of the machinery that we use to identify colored objects. In contrast to color, how do we conceptualize pain? There are some important differences between the two, which I would like to highlight, and in a sense, becomes a discussion throughout my lecture here. So, and I will simply give an example. I'm assuming you are probably sitting down and listening to this lecture, and in a sense, I will in fact I have my small joke that I need to share with you. Basically, as I keep talking, you will probably start getting bored. It's like, okay, when is this lecture going to end? And in that sense, as you're sitting down in your chair, you start fidgeting, right? Now, one idea of that fidgeting is that you're just bored with what I'm saying. Another idea is that, in fact, you are trying to protect your tissue from injury. And in a sense, you are using the machinery that we commonly associate with pain perception to protect the tissue. And in that sense, part of my overall discussion today is that the pain machinery that we commonly look at as either a sign of injury or a sign of pathology, especially in chronic pain, it is actually also a system that protects the tissue from injury in general. And in a sense, that as you are sitting on your chair, you are putting on average about 60 kilograms of weight on that chair, which means you have that much pressure on your behind as well. And that activates nociceptors. Although nociceptors are activated, you do not feel pain until probably within half an hour after my lecture begins, in a sense that that chair that was a comfortable space that you were sitting on and listening to me, of course, as I go on and on, becomes uncomfortable and becomes a painful chair. Now, nothing of the properties of the chair have changed, but your perception of your interaction with that chair has dramatically altered. And in that sense, in relation to color perception, where we actually at least have a veridical object with some wavelengths associated with it that we can extract from, in the case of the chair, the properties of the chair are not informative of my pain, right? Of your pain, of pain in general. Yet that chair can become painful. So fundamentally, what I'm saying is that pain is a subjective state, right? We generally all agree on that, but with an objective machinery behind it that we can quantify and identify and study. And I will spend more of the time to describe those properties. Let me move on. So um, fundamentally, we're discussing detecting danger and responding to it. And this is a figure I have copied from Kevin Mitchell's book that was published just a few years ago. It's a fascinating book. I recommend to read it. But this is a cartoon diagram of a unicellular organism that obviously does not have a brain, does not have neurons, but it will have receptors on its surface to detect the environment and react to the environment. So the prototypical example would be a paramecium, for example, which has a flagella that can be used to move in the environment. And to survive, these unicellular organisms need food and need to avoid danger, right? So, and in a sense, here we see that the arrow from information towards the flagella would be enhanced towards the direction of food and away from the direction of danger. So all organisms, in a sense, have nociceptive machinery, right? Whether they have a nervous system or not, survival of life has to have a mechanism to signal where is the dangerous environment to be able to avoid it, and in contrast to where is rewarding environment to go towards it. So the DNA machinery and its transformation and its generation of specific proteins becomes one way of looking at even the unicellular organisms as having adaptive mechanisms. They have to adapt to their environment. They have to predict their environment in a sense that, when, the diurnal cycle is a standard example of predicting the environment. And they have to have both approach and avoidance behaviors. So in that sense, we can think of any receptor on this organism as providing information, and that information has value because that value of whether it's food or danger, and it has a meaning. The meaning is approach and avoid. So those fundamental concepts are preserved across all living organisms, and of course they get a lot more elaborated when we have a nervous system and when we have consciousness as well, right? So from that simple example, I just want to conclude briefly that complex behaviors are essential for all life. The planet is a noxious environment, and to survive, you have to navigate the noxious environment. And escape behavior is also used by all organisms. Therefore, so this comes to a rather logical inconsistency that avoidance behavior is available for all organisms, and so behavioral assays cannot be considered as evidence for or against pain perception. Therefore, one has to conclude that pain cannot be defined by behavior alone. Yet all of our animal research is grounded on interpreting behaviors. So instead, to make our conversation logical, one has to say that all animal research studies nociception, the machinery that can and may be associated with pain, but not pain. And we can only study pain in humans where the subjectivity can be verbally described. So moving on to more complex organisms, I will move on to the more clinical topic very soon. Obviously, once we have a nervous system provides much more efficient behaviors, much faster responses to the environment, and importantly, integrating of information across many dimensions. So a given synapse, in a sense, becomes a location where information from various sources of information can be summed up and made a decision on. And also, every synapse becomes an opportunity to change the gain of the system, to change the amount of importance of that system. Essentially, a synapse is where you change the relevance of that information to behavior by either downregulating that synapse, the amount of information transmitted from presynaptic boutons to postsynaptic elements, or upregulating it, giving more relevance to that information. Okay, I have put all of this kind of basic information because I want to emphasize that pain, acute pain and chronic pain are fundamentally underlie these specific processes, and the mechanisms, molecular mechanisms, cellular mechanisms underlying them is fundamental to what we treat and how we treat in pain in general. This is a slide I have taken from a recent paper from Alan Basbaum's group. It was just published a few months ago, maybe. And basically, it's a nice summary. It says that in humans and in vertebrates, at least, we have very elaborate mechanisms for measuring nociception and reacting to nociception. Fundamentally, it's the peripheral nervous system, the nociceptor end organs, in a sense, innervating tissue. All tissues, essentially, in the body have nociceptive afferent input from them. That information goes through the dorsal root ganglion into the spinal cord. And importantly, especially in vertebrates, we have very specialized afferent fibers, right? Small unmyelinated or small myelinated fibers. These are the A, delta, and C fibers that transmit preferentially information about the noxiousness of the environment to the spinal cord and then to the brain. The spinal cord is the first synapse, so it's the first opportunity of integrating information across dimensions and of changing the gain. And this is where we will discuss, spinal cord or central sensitization. And then the spinal cord provides the information set for that to the rest of the brain to multiple pathways, to multiple brain targets, and also the brain where this information is going to be integrated into a subjective state of pain, right? Which only humans can report to us. And we do not know. We can surmise that, our close relatives, dogs and cats, suffer from pain, but we really don't know. And it's a closed system. Their subjectivity is not available to us. Importantly, there is also a top-down regulation. This is a descending modulation, which in fact, the evaluation and the perception at the cortical level of pain then influences the gain of the system within the spinal cord. And in a sense, this descending modulatory system provides yet another amplification, integration venue to the incoming information to the spinal cord. So I will mostly concentrate on the brain because this is really where my research has been for the most part. And also because when we want to talk about pain, talking about nociception in the periphery may not be informative. So this is my next important message that I want to give you, is that pain is not nociception. Nociceptive activity, as I started from the beginning, nociception-related mechanisms exist in all organisms. It is necessary for survival because the environment is noxious. From the human viewpoint, and all vertebrates in general, we can think of nociceptive activity as defining the limits of our peripersonal space, in a sense that I can extend my arm or my elbow to only a limited extension, and I don't break my bone. I don't break my bone because my nociceptors, in fact, inhibit me from doing that prior to even feeling pain. So my mobility, my rate of running, all of those things are essentially limited by a sphere of nociceptive inputs that inhibit the system from doing things that would just break me apart, right? So that without me consciously feeling pain, my nociceptors are constantly telling me what not to do, right? They unconsciously protect the body from injuries. On the other hand, we think of pain as a conscious signal, as a conscious signal that says, okay, the machinery did not work well enough, or you did something stupid, so we need now to change our behavior. To change the behavior, you have to have conscious signal that will teach the organism, the brain, to change behavior. So in that sense, okay, my definition, this is not the IASP definition, it's my definition, is that pain is a conscious signal of the failure of those receptors to protect the body. That they are still mediated by nociceptive signals, but the nociceptive signal has become conscious because their protective ability has failed. It's a nuance, but I would like you to appreciate it. So let me move on. I like this slide. This is from René Descartes back in 1644, and this is his depiction of what is perception in a sense, and it's wonderful in that it captures a stimulus, the hot fire, a transduction from the fire to through some mechanism of a signal that the nerves transmit from the tissue all the way up to the brain, where in the brain we have perception. And again, uh, nociceptive mechanisms that give rise to pain, similar to other sensory modalities, have their unique machinery, right? Nociceptive afferent fibers, their spinal cord pathways, and their integration in the cortex. Now, I will spend the rest of my time mostly talking about the brain. And in the brain, we can look at pain mechanisms mediated by nociceptors by a whole variety of technologies. Here, I'm simply showing that we can, in fact, look at the brain anatomy and how the brain structure, the neuronal properties of the brain, and how the brain axonal properties, this is the fibers that transmit information from one area to the other, what their properties are. What is the neuronal activity in the brain, right? If we have a noxious, painful pain giving rise to pain stimulus, we can identify a signal. And so the stimulus is in black here. And the brain signal from this region of the brain, where the hot spot is located, gives rise to that signal, which nicely correlates with the stimulus. And so we say that these regions of the brain are correlated to the stimulus. And if we then say it was a painful stimulus, then they are correlated with the reception of that pain. We can also study the brain from a network viewpoint, and the network viewpoint is simply that this information that exists in the brain, how it interacts across regions, what brain area talks to which brain area, and how the brain as a network is processing nociceptive information and or reacting to painful states. Okay, again, I want to go back to the brain and now, again, give you a very brief contrast between the data that has been accumulated over the last 30 years or so with brain imaging of what brain areas are involved in pain, in visual perception. This is the slide on the left. This is a meta-analysis of okay, here I can see it's 3,110 studies averaged on top of each other of what brain regions are activated when a study is, when we do a vision-related study. And you can see all the red regions are the brain areas that are activated. This is in 3,000 studies. If we think of 10 subjects per study on average, at least, then this is the average of 30,000 people and their brain activity for any given visual task. In fact, if we simply look at the amount of tissue that is activated, it's about 10% of the brain. And if we look at the hottest spot, that's the green lines identify the highest probability spot in that region. That spot gives us a probability of 10 to the minus 23 of that being activated by chance. That's an astronomically high number in a sense that the chance that it's very unlikely that that region would be activated for a visual task, would not be activated. Okay, so we have very high confidence that that region of the brain will always be active when we do a visual task. Okay, that's great. What is our confidence, or similar confidence about pain if we do the same analysis? And that's this panel on the right. And first of all, you can see that essentially, so in this case, the number of studies is 500 studies as opposed to 3,000 for pain. But it's, again, it's the average of 500 studies that we're looking at. And within those 500 studies, again, you can think of this as the average of 5,000 people's pain perception, you can readily see that the red areas do not overlap with the red areas for vision. Pain and vision subtend essentially separate brain areas. At least the primary signal is in independent areas of the brain. And in similarity to vision, again, we see 10% of the cortex being activated for painful tasks. And our confidence, statistical confidence for its highest value is essentially the same as in vision. So about the same amount of tissue is activated with the same confidence, statistical confidence of its activity being related to pain as opposed to any other condition. But there's a big difference between the two. Again, the fundamental difference is that in the electrophysiology studies in rats, cats, monkeys, and in humans show that about a third of the brain neuronal activity are in fact dedicated to visual information processing. In contrast to that, for pain, in fact, we cannot find a single dedicated cortical area. So although the cortical circuitry seem dramatically different, the process underlying them is also dramatically different in that visual processing has a lot of machinery purely dedicated to vision. Pain, instead, we have to think of it as an integration across multiple modalities that give rise to this activity pattern. And okay, let me qualify that all of this data that I have discussed here is for acute noxious stimuli in healthy subjects. Okay, so this picture starts to change very dramatically as soon as we move to chronic pain conditions. So then another question that comes up is, where in the brain is pain perceived? There are no nociceptive specific columns in the cortex. If no such columns exist, although, as I showed you in the slide here, there are definitely brain areas that are more dedicated to processing nociceptive information than otherwise. So multiple brain areas process nociceptive information, but pain, we think of pain as a cognitive state, a unified state, and in fact, our recent data shows that we can capture that data from anywhere in the brain, in that pain maybe has specific processing units, but its perception includes the whole brain. It's a whole brain state. And the corollary evidence to that is that there is nociceptive information in the brain, but unless that nociceptive information is processed and transmitted throughout the brain, then the nociceptive information does not turn into a conscious subjective pain state. Okay, very brief issue. At what age does the fetus begin feeling pain? This is a topic especially relevant to the US. It has been abused by the Supreme Court to, for their decisions about abortion issues. But the real scientific question is, at what age do nociceptors innervate the spinal cord? At what age is there conscious subjective valuation of the environment? And I'm not going to go through all of this, but those are very clear scientifically identifiable targets that one should use rather than, and instead, the society in general has taken advantage of conflating pain and nociception and has made extreme statements that are just incorrect. Okay, I'm going to move on to from pain, acute pain to chronic pain. And again, I have a simple message: chronic pain is not the persistence of acute pain. Okay. And over the last 20, 25 years, my group and many other laboratories now have been studying the human patients, chronic pain patients, their brain anatomy, their brain function. And we have unequivocal evidence that the brain anatomy and functional properties are different in chronic pain from that of acute pain. And that different types of chronic pain show different brain properties. And there are at least a general concept that the transition from acute pain to chronic pain involves very specific brain limbic properties. The limbic brain is essentially, we will equate it to the brain regions that have to do with emotional evaluation of the environment and emotionally driven learning processes. And so overall, we think of chronic pain as having risk factors in the brain that identify who in the future will develop chronic pain. And brain reorganization, those are adaptations of the brain essentially to the suffering of chronic pain itself. And both of those things are properties that put the brain in a uniquely different state that clinicians know very well, becomes very hard to treat and very hard to reverse. So going back to my brain imaging technology, very briefly, there is evidence now from many different laboratories for various types of chronic pain conditions that the brain anatomy, gray matter properties, brain axonal properties, brain activity, and brain network properties, all of them change, we think, in very specific ways, depending on the type of chronic pain we have, although the evidence is not as clear in some types of chronic pain versus others. And again, coming back to Descartes' cartoon of this information transmission from the periphery to the brain, one could simply generalize and say that physiological studies and anatomical studies show that there is reorganization of information processing across all levels of the neuroaxis when pain becomes persistent and or chronic. The receptor, at the level of the receptor, sensitivity of receptors to stimuli change. This is peripheral sensitization. Related to the injury site itself. Then there's spinal cord sensitization, right? That is accompanying the state of chronic pain. And we have shown, these are some of the first evidence that we have shown in the past, that brain activity and brain anatomy, both of them are different in chronic pain patients versus healthy subjects. And again, coming back to this overall viewpoint of the machinery of pain, there is reorganization across all three levels, right? In the periphery, in the spinal cord, and in the brain. And the debate, the ongoing, in fact, research in the field overall relates to which part of this machinery is more important in which states, where should treatment be targeted, and which one would be more efficacious in a sense. Pharmaceutical companies, by and large, have put all of their money, a lot of their money, let's say, on peripheral specific channels that are associated with pain and or spinal cord circuitry. So this is the two targets that pharma has been trying to identify new targets for. Much less effort has been done at the level of the brain. The simple excuse in the past has been, well, the brain is so complicated. If you can do it in the spinal cord level or in the periphery, it will be much more specific and much more efficacious. Unfortunately, the evidence has not paid off, in a sense that we really have not discovered any new drugs with those approaches. Whether On the other hand, personally, I think there's much better chance of us of uncovering far more efficacious treatment options if we unravel and identify specific targets in the brain. I'm not going to discuss that today, but that's essentially what drives the research in my lab, what has been driving the research in my lab for decades. But let me show you some of the evidence that we have published over many years, and essentially about the transition from acute to chronic pain and the underlying brain mechanisms that we have identified. And the concept is very simple, that there is a time arrow from acute pain to subacute pain, which is a persistence for a few weeks up to multiple months, to transition to chronic pain. So that's the time arrow of the process. Within that time arrow, we think of having risk factors. Those are predispositions. The risk factors, together with an injury, an acute event, a trauma, or a combination of a trauma and injury, puts the organism into a transitional state. In this transitional state, the system starts adapting, and it's going to adapt either to the pain going away and the subject saying, okay, I've recovered, the healing process has finished, or the healing process continuing, but the pain persisting, and that becomes into a maintenance of the pain, which becomes a chronic pain state. This is the overall concept that we have been pursuing for underlying mechanisms for many years. From a person who who insists that nociceptive afferent information is necessary and sufficient for pain perception, all stages, they would still believe in this concept, but they would explain all the stages of this as being driven by primary afferent and its reorganization, and primary afferents and their interaction with the spinal cord circuitry and its reorganization as being sufficient. And in that sense, you would target your treatments to those machinery, in a sense. In contrast, we think that, again, as I mentioned briefly earlier, that limbic brain circuitry, the brain's emotional evaluation circuitry, underlies the risk, the predisposition for chronic pain, in a sense that one subject thinks of pain as more impactful to them versus another subject, very simply. But and that interaction of that circuit, the properties of that circuitry, together with the injury, with the injury event, their sum, 1 plus 2, creates the properties of the transition, where the emotional learning circuitry now defines the pathway, whether to transition into a chronic pain state or into recovery. So very simply, I'm dividing the brain into two pieces. The neocortex, this is the conscious perception machinery, while the subcortical limbic circuitry, it includes hippocampus, amygdala, nucleus accumbens, and their interaction, all of which sort of creates the coloring, the emotional coloring that is transmitted to the cortex, and also creates the learning signal of evaluation with which we either amplify or decrease the importance of the nociceptive signal that's being transmitted from the periphery to the cortex. So obviously this is a simple approach, but in a sense, this gives us a global, large, high-level concept of mechanisms with which we can think about the transition from acute to chronic pain. Here's another way of looking at the same system. Again, this bottom part is this limbic circuitry, which very generally we can think of it as reward, addiction, mood, chronic pain, all of which are being processed as to their affective emotional, motivational valuation, while the cortex is essentially looking at its conscious state. So both of them are activated with nociceptors all the time, right? But in a sense, most of the time does not reach the conscious state, but but the nociceptive activity is simply driving subconscious circuitry that control behavior without the need of awareness. But of course, when we have an injury, that nociceptive signal ends up feeling pain at the cortical level, and that level of the pain and the value of that pain is the interaction between these two regions with each other. And in a sense, if the cortical machinery can suppress this emotional system, then the pain will go away. On the other hand, if it is the other way around, if it is unable to suppress it, the emotional circuitry will drive and reorganize the cortical representation of this system and transition the cortical perception into a chronic pain state. Let me show you just a little bit of evidence along these lines, and I will try to finish my lecture. This is one of our very old studies about brain activity in chronic back pain patients. On the left, again, I have this meta-analysis. It's an older slide. This is a meta-analysis out of 224 subjects for acute pain. This is the brain activity that I showed you earlier on in an earlier slide relative to vision, but it's essentially the same result. For pain studies, we see these typical brain regions activated. In contrast, for acute pain, I'm sorry. In contrast, when we actually look at brain activity in the absence of a stimulus, when subjects simply rate how much their back is hurting, and we map that into the brain, we identify medial prefrontal cortex activity. This is an area of the brain which would be residing around here, somewhere around here, which is not in the acute pain. So it's a unique area of the brain. Yet if I plot the activity in this region across all the subjects, I see that their pain intensity at the time when the brain scans were done very nicely correlates to that brain region. So that their back pain perception-related activity resides, at least is represented best. It resides everywhere in the brain. We agreed on that earlier on, but it is best represented in a region, again, in the medial frontal cortex. This is a region that has to do, again, that's massively integrated with the limbic brain. And in a sense, we think of this, that this is an evaluation signal that the subject is literally conveying to us the idea that this pain is not coming from the outside. This is the nociceptive signal in a sense, but this is a emotional suffering of the subject themselves. Another concept I want to briefly introduce here, again, in this transition from acute to chronic pain, we can bring in subjects at this subacute, acute to subacute state, and follow them over a year, 55 weeks in this study, over time, looking at their brain properties over time. And essentially, the concept here is that if I have brain properties at this time that can predict who 1 year later becomes chronic versus not, then these are risk factors. On the other hand, processes that are changing over time are adaptations that are happening. In a sense, everybody enters into the study with the same properties, and then over time, they bifurcate into chronic pain versus no pain, and then we can study their properties. This is the actual data of the pain ratings for about, I don't know, 70 or 80 back pain patients. When they enter the study, by definition or by design, everybody starts at the same level of pain, around 5.5 out of 10 NRS scale of back pain. And over time, over 60 weeks, you can see half the subjects have exactly the same pain over the year, while the other half of the subjects, their pain is continuously decreasing. So the inverse triangle subjects are the ones who are recovering from their pain, while the black squares are the subjects whose pain is persisting. So now we can ask, within this population, what brain properties define the two groups? Okay, before I get there, actually, let me just show you how the brain activity, in fact, is changing over time within these two groups, right? And this is a paper that we titled Brain Activity as Shape-Shifting with the Transition from Acute to Chronic Pain, in that the brain regions literally are changing in location in the subjects who become chronic pain patients versus the ones who are not. And this is a summary of that data. Again, within this time window from subacute to chronic pain over visit 1, 2, 3, and 4. This is at time 0, 7 weeks, 30 weeks, and 55 weeks. You can see all subjects at time 0 have brain activities that are similar with each other, and they're similar to acute pain. Okay, so an initial early back pain subject essentially has brain activity properties that match acute pain. Over time, the ones who are recovering, this is SPPR, over 1 year, their brain activity is going away. I'm sure they still have some brain activity, but it's too variable and too small, the perception, for us to capture it in this small cohort of subjects. The subjects where the pain persisting over time are the ones where, in fact, the brain activity decreases in these areas, and you can see that over time, while it starts being activated in multiple limbic regions. So the brain is becoming more emotional, the perception is becoming more emotional, self-referential, and uniquely different from acute pain. So that's the evolution over time of brain activity from the transition from acute to chronic pain. And I want to share with you another concept here that I think is quite informative. And basically, if we think of the chronic pain state, how does the chronic pain state impacts information sharing in the brain? We discussed earlier that information is shared across the brain for conscious states. And there's a lot of literature of what brain areas are hubs, which are not hubs, where the information is concentrated most for any given perception. But here we want to look at the brain as an overall network and how the chronic pain, in fact, can be viewed as an decreasing information transmission in the brain in general. I'm not going to labor the details of the technology. Basically, we take the brain and we generate from it a network, basically the brain activity into a network, which brain area is talking more with each other. That's too complicated to analyze. Instead, we simply look at any given area and how many other areas it talks to. So that we call this degree, and we simply measure that for every region of the brain. And if we do this, we end up with, in healthy subjects, a map like this. Now this map is showing what brain areas are talking most to other brain areas. Now, and then we can compare any given chronic pain patient's map of what brain areas are talking with each other to the healthy subjects, and then we can identify the distortion between them. And the details are not very important, but we can see that in chronic back pain patients, complex regional pain syndrome, and osteoarthritis patients, across the whole brain, there's a distortion of information sharing. The information sharing overall decreases in brain areas that are hubs, that is, the brain areas that are most connected to the rest of the brain are decreasing their amount of information sharing, while the brain areas that are less connected become more connected. The amount of this information decrement, in fact, across each subject, these are each one of the dots here are individual subjects, are nicely proportional to the amount of pain these subjects have, independent whether they're chronic pain patients, back pain patients, CRPS patients, or osteoarthritis. Across all three groups, we can see that the distortion of the information sharing is proportional to the pain. What that says is that the more pain I have, at least chronic pain, um, uh, and and we have tested this. It is not true for acute pain. In fact, this is only specifically for chronic pain. The more intense my chronic pain is, the more I am disabled in the amount of information sharing in my brain across the whole brain, anywhere in the brain. So that's another way of looking at the cost of living with chronic pain and how it impacts our cognitive abilities in general. And just showing you some data about the brain processes that can predict a priori, before the subject develops chronic pain, brain properties can tell us who will develop chronic pain into the future. And prediction is important for two reasons. Prediction obviously gives us clues of how to stop the process from happening, right? So we can intervene prior to this process happening. Secondarily, the prediction ends up tapping into mechanisms that have to be directly or indirectly causally related to the mechanisms that are creating the transition. Therefore, they actually reveal to us mechanistic properties of the brain that are clinically and scientifically important to our understanding of what is chronic pain. So I'm showing you some very little data. Again, this is the same data set as I showed you earlier. These are the subjects that half of them persist with pain over 1 year, the other half continue to decrease in their pain. Now, if we look at a very simple brain property, two regions of the brain, nucleus accumbens, this is a brain region that has to do with reward and motivation, and its connectivity to the medial frontal cortex. This is a brain area that has to do with self-evaluation. The amount of information shared between these two areas, the more they are related with each other, the higher the risk of these subjects developing chronic pain. That relationship is high at time zero in the subjects who in the future will become persisting in comparison to the ones who are recovering. And that relationship stays constant over the whole 1 year, even though the pain is changing in one group and it's not changing in the other group. So it's independent of the pain, but yet it's predicting who will develop pain versus who will not develop pain. So in this slide, I'm basically showing the statistical confidence of our results. Essentially, this data shows that we are about 80% confident that we can identify who 1 year later will develop chronic pain, and these results are validated within our own unbiased data sets, and it's been now also replicated by multiple labs, both within the US and in Europe as well. So, and this I'm spending time specifically at this, looking at this specific biomarker. We have other markers that predict chronic pain, which I will skip over, because this circuitry itself is important from the viewpoint of what is addiction in general. This circuitry, this frontal cortex to the nucleus accumbens connectivity, is an area that is implicated in cocaine addiction, for example, alcohol addiction, in smoking, and so within this general concept, we can think of the brain becoming addicted to nociception, in a sense that this circuitry is amplifying the nociceptive signal, its emotional valuation, and in a sense, it's driving motivated behavior to create the chronic pain state. And let me just show you a little bit of evidence that's consistent with this data in animal models. This is an animal model for chronic neuropathic pain. In the case of animal models, we can very nicely study the transitional state, but we really cannot study predisposition because these animals are designed to show persistent pain behavior overall. But very briefly, I want to show you just some data from, these are now brain slices from nucleus accumbens in mice that have had a neuropathic injury. And 1 week later, we look at these neuronal properties. These neurons within nucleus accumbens show increased activity compared to the healthy animal, to the sham animals, the neuropathic animals. Overall activity is increased in a very specific population of neurons within this region, only the neurons that have D1 receptors on them. So this is 1 week after the injury, and the anatomy of these neurons change. In fact, they shrink. Their dendrites are shrinking, and their synaptic properties have changed. Their inputs have decreased. There's less input coming from other areas of the brain. And in fact, the dopamine, so these are dopaminergic neurons, the amount of dopamine that comes in on these neurons is itself decreased as well. So again, it's important in that this is back translational studies. We have taken the information from the human data and looked into the animal brain and see its correspondence and its cellular, molecular, pharmacological properties overall. And in fact, we can now give these we can manipulate the neurons in this region by by virus manipulation of increasing or decreasing the excitability of these neurons in this region. And just by changing those properties, we change the animal's behavior. We can either increase or decrease their tactile allodynia sensitivity by simply changing the excitability of these neurons. Just to show you that, in fact, the human brain imaging data can give us very rich, very fruitful directions with which we can study the brain circuitry at a very fine level. But just to keep things more clear, I want to also emphasize that we can do similar, this was neurons within nucleus accumbens. We can do similar manipulations in multiple areas within the limbic system. And each one of them, or all of them in a sense, show different ways of manipulating the neuropathic pain. So we don't think there's a specific center. These systems are highly integrated with each other, and their interaction, of course, is specifically important and pharmacologically unique, but we don't know the details of these things. Yet, chronic pain behavior can be manipulated through multiple nodes within the limbic system, just like chronic pain is perceived everywhere in the brain at the same time as well. So I'm almost done. What I want to emphasize here is that these stages, so overall, what we have learned and how we can generalize from what we have learned is that these risk factors, the injury and the transition, will have distinct properties for different types of chronic pain. Osteoarthritis versus fibromyalgia versus back pain will show different involvement of the peripheral, the central, and the emotional circuitry and their interactions. But what I also want to emphasize here is that nociceptive inputs from the periphery must always be included in our models, in the sense that a back pain patient always reports the pain in the back, while a headache patient reports the pain in their head. And those somatic information is a nociceptive input from those tissues, and that is part of the model that needs to be considered as well. Again, this is another way of showing the data, again, in a sense that the nociceptive signal uh, engages the emotional limbic system as well as the cortical conscious system. And the relative weights, the A and B of these two systems, are uh, going to be different for different conditions. And in a sense, from a clinical viewpoint and from a treatment viewpoint, how much do we treat the peripheral nociceptor, the emotional circuitry, and or the cortical circuitry becomes an important issue that one could start debating. And in many ways, uh, a lot of our non-pharmacological, cognitive behavioral manipulations are primarily uh, treating the B pathway, right, while keeping the A pathway intact. And the recent evidence, there's a lot of recent evidence now with high quality evidence that, in fact, just treating the B pathway with cognitive manipulations or even things like yoga, etc. All of them do show benefits in chronic pain patients. And we are literally just looking at pathway B. So I want to simply finish by saying that brain imaging provides a very rich way of understanding chronic pain, and it has opened up mechanistic concepts that we did not have before at all. And our reverse translation from the humans to animal models provides us with causal mechanistic information that translates to literally drugs, novel drug treatment opportunities. Um, and let me just qualify that I discussed chronic pain from the viewpoint of the brain becoming addicted to nociception. That's one viewpoint, right? We can just make another as impactful arguments in another lecture that, in fact, emotional learning is just as important as the amplification, emotional amplification, and those things are integrated processes with each other. And again, these concepts have the opportunity of providing us with novel therapeutic pathways. And although I cannot specifically tell you of one today, I think the near future should show us opportunities along those lines. With that, I will stop my lecture. Thank you.